Right. Very, very good afternoon, ladies and gentlemen, and welcome to our final webinar on the report by the Mental Health Task Force, which you will remember was put in place last year following the observation by government that there was a very definite increase in mental disorders in our country. And the task force was, if you like, tasked with attempting to establish what could be done. Sorry, first of all, what the problem is, and secondly, perhaps more importantly, what we as Kenyans can do about this challenge. We've gone through different chapters of the report in the last few weeks, and this the last week we will consider three chapters, the final three chapters, which address mental health financing, research and data, and finally the role of leadership and the laws that are around mental health and what needs to be done. To discuss these chapters, we have Dr. Olayo, who is a public health specialist, currently working for the World Bank Group, and who was very instrumental in the formulation of the chapter on financing. So he will be the first one to go. We will then have Dr. Lynette Ongeri, who is a psychiatrist and a scientist in the true nature of science. She does a lot of research at KEMRI, and she is the right person to tell us about the research and data landscape in mental health. Oscar Gadua is a renowned psychologist, a forensic psychologist, who still teaches at USIU, a very invaluable member of the task force, who did a lot of work in the area of the law and as it relates to mental health. And he will be giving us his thoughts as contained in the report on leadership and the law. To wrap it up, Dr. Simon Juguna, the Director of Mental Health in the Republic of Kenya, will take us through in a few minutes what all this means and where this is taking us to, and how will this report be translated into action as we move forward. We started significantly late today, so I will waste no time, because time doesn't wait for any man or woman. Bernard Olayo, you have 10 minutes to do your presentation.
Thank you very much, Dr. Njenga. Just to confirm that you can all hear me well. I think it was an absolute
It's very well, we can hear you. Proceed.
To be part of this process. And I wanted to look at this more from our journey towards universal health coverage, which is a big priority for not just the president, but Kenyans as a whole. So in the work that I do, we take it beyond the proclamation. So if the high-level policymakers have decided that, we want to achieve UHC, then it's our responsibility to break it down into what exactly does this mean. So zeroing down on mental health, we think of a package of services, a set of services that everybody with mental health conditions or mental enhancing environment requirements need to get. They are created into what you would consider to be an essential package. Then that package is costed so that we know exactly how much money would we need to pay for these services. And then we can spread it on an average for the whole population generally because we don't know who's going to require these services when. So the average we use is something that helps us for planning purposes. And by all estimates, the costing for a country like Kenya, we need a per capita allocation of around 250 Kenya shillings per person per year to deliver that package of mental health services. But where are we in terms of financing for mental health? We are very far off that mark. By estimates, when we were working on this, instead of the 250, we are somewhere just around 25 to 30 shillings. So there's a huge gap between 250 and 35 shillings that is currently allocated. And therefore, the following bad things happen. So when you don't have a government or a pool procurement, a pool system that pays for these services, then individuals that need this care are left to their own devices. So they pay for the services as they need them through what we call a very efficient system of out-of-pocket expenditure. So you pay to see the doctor, you pay to see the psychologist, and you pay to buy your medicines. And therefore, this is during the mental health task force interviews, we did realize and we did corroborate that with our secondary research that the bulk of mental health services in Kenya is paid for through out-of-pocket expenditure. In other words, the families bear this burden because generally, again, for most of these patients, they have lost work and they have no income, and therefore the burden of paying for this care falls on the family. That's the tragedy that people, especially those with severe mental illness, go through in Kenya today. Now, the other challenge that we did come across when you're looking at financing for mental health is that unlike malaria or some other diseases, these people tend to require lifelong treatment. And therefore, if they have to get their medicines every month for the rest of their lives, the burden to that particular family is impoverishing what we call the catastrophic health expenditure. So as a result of making every effort to access health services, these families tend to fall into poverty for two reasons, because the principal person cannot work. Sometimes they need to get a caregiver who also can't work. And lastly, because of the direct costs of those services. So that is the tragedy that we are dealing with at the moment, and therefore we need to rethink of how do we deal with this. The other impact that the mental health task force saw was that even if you look at our tertiary care, the government facilities, they were in a deplorable state. The toilets were terrible, and the living conditions for those who are in these settings were very, very bad. That's also another sign that we are not putting in enough resources to pay for these mental health services in the country. I know Dr. Njenga gave me 10 minutes, but I think we did come up with a few recommendations that we could think about to try and change the situation, because it's not just enough to highlight the problems, but also to propose some solutions that we can use to help change the situation. So I have three that I will talk about. The first one is that we need to increase equitable funding for mental health services. In other words, every effort should be made to reduce the reliance on out-of-pocket expenditure by the people who need these services the most. And for purposes of planning, I think we need to urge the government to urgently increase the allocation of mental health towards mental health services, away from the very minimal allocation that we currently have towards the $2.50 per capita allocation, or 250 shillings thereabout. This would help to solve the problem of access to medicines, but also the infrastructural conditions where these people are, and generally save these families from poverty. The second one is to look at what NHIF is currently doing. The coverage for mental health services is quite limited, so we could expand the scope to increase the number of services that they would cover. With mental health conditions, many people would not require inpatient services early on, and they would require more of outpatient services that can actually help to save them from deteriorating and eventually requiring inpatient services. These services are generally not catered for in the current package of NHIF services. And therefore, we need to move towards risk pooling for mental health services, where we try and ensure that all the beneficiaries of NHIF have a much more enhanced coverage of mental health package in that NHIF coverage. That can help to solve the problem. And then the last one is to think of not just providing services for severe mental illnesses that are paid for by the government, but also to put resources towards the more preventive or mental health enhancing conditions that could help to reach very many people. These services are currently not paid for, not just by the government programs, but also the private health insurance. And they would have a much bigger impact. They're much more cost effective than waiting for when people are very ill, and then we spend a lot more money at that point. Let me stop there, and then I'll take up more questions when the question time comes. Over to you, Dr. Njenga.
Thank you very much, Dr. Olayo. I will take two messages from your excellent presentation. The first one is a number, the number 250 shillings. What you've told us is that for us to finance mental health adequately in this country, we need to put aside 250 shillings per person per year. We are currently putting 25 to 30 shillings, which is about 12% of what we really need for this purpose. And it's therefore not surprising that when the task force went throughout the country, the state of the physical facilities was deplorable, to put it exceedingly gently. I think we now must move on to listen to Dr. Lynette Ongeri, who also has 12 minutes. The time will keep increasing as we go along. So, Dr. Lynette Ongeri, you have the floor. Thank you, and you'll talk to us about research and data.
Thank you very much, Dr. Njenga. Allow me to share my screen to see if it's possible to see my slides. I don't know if you're...
Only those in power can help you to share the screen. The rest of us have no such powers. I don't know, maybe Priscilla or...
Priscilla, could you... I'd sent my presentation as well, so... Oh,
so,
are you able to see it? Are you able to see the presentation?
No, I see nothing, completely nothing.
Okay, then I might, if you're not able to share the screen, then I might be forced to just talk.
I think Dr. Ari,
Talk through
continue
it.
talking even as Priscilla and her team try to to do whatever they need to do.
Okay, that's okay then.
All right. So proceed, please.
All right. So my topic, it was very diagrammatically presented, but we shall go back if I'm able to actually share that screen. Oh, I think I can see it now.
It is well done. Good.
Very good. Okay, thank you very much. So my topic was actually just go back slightly. Yeah. On research to inform policy and practice. And in this area, I was going to really go through what is the pathway of research. How does research move to the point whereby now it's evidence-based, it's termed as evidence-based practice. So we'll go through that pathway, and also we'll go through what we found in terms of research, what exactly we found as the task force, and then we'll go to what the recommendations are as pertains to research. Next slide, please. So this is almost like a summary of what I'm going to really break down in the next slides, the pathway from research to practice. Usually when we conduct research, the most important thing is once this research is there and the data is out, the dissemination process whereby we share our results and our findings. And if the results, if the policymakers feel like these results are actually important and they make lots of sense, and whatever it is that the intervention looks like it's actually a good thing, then it goes through the policies and further testing through various interventions, and finally it goes through, it's institutionalized into practice. Now we'll go through the different components of this. Just next slide, please. So we've talked about mental health research. And once the research is found and we want to disseminate our findings, majority of the people end up disseminating their findings towards just what we can see there on the left, to the peers. To the peers means that once we publish our work, then we feel like we've done justice to the research. Or once we've reported it in a conference, in a seminal paper, or in a research report, we feel like we've done our work. Most of the scientists feel like they've done their work. But that is really where the problem comes in, and it means that that research is not pushed to policy and it's not pushed to practice most of the time. So we also have to have this other line of research whereby there's what we call the advocacy arm of it, whereby we talk to stakeholders and also the public as well, on different stakeholders, including the ministry and other policymakers, as well as the public, on what our findings were, kind of sort of what we're doing here as well. So through this, we have to be able to develop policy briefs, so make our findings be able to be executed by even the policymakers, see how useful our findings can be, so that they can be executable, and then also talk to the public through press release and also through mass media reports. So it's important that whatever our findings are, that it's disseminated through these two arms for us to be able to move research to policy to practice. Next slide, please. So once we've disseminated these findings, our findings through the processes we talked about, the advocacy and also to the scientific world, then there's also now the aspects of development of policies and interventions. Here we sit down, we've done a couple of this with the Ministry of Health, with Dr. Njuguna, and whereby we develop practice guidelines based on these policies that we've been developing, and also look at program delivery strategies and legislation, what can legislate these particular policies, and how do we put these policies into practice. So once these guidelines have been written and the delivery, the strategies, who is going to deliver, who is going to, at what setting these particular guidelines are going to be done, then we have to also not stop here. For it to go into practice, it can't just stop at guidelines. The next click button. Yes, so it can't stop at just the guidelines. Once we've decided, we've developed these policies and interventions, then we have to test these interventions. We train people on whatever intervention it is that we found out in our research earlier. We train people on implementing it. For example, the MH gap training. We have to train people, and once we've trained it and established it in certain areas, we have to evaluate it and see, does it really work? Yes, it showed that it worked in our initial research, but we have to see how feasible is it in this on a scaled kind of platform. How cost effective is it, for example? How acceptable is it? And are people able to actually embrace it? And from this, we can even build more research questions based on what we come out with. And at that point now of evaluation is once it passes that end and it's scalable, then it becomes institutionalized as evidence-based practice. So that pathway is important because we understand that there are different areas that we have to move through for it to move from research to policy. Next slide, please. So this is just a repetition. Next slide, please. And back to the summary of moving it from research to dissemination in the correct way, policies, to develop policies and intervention, and then to test these interventions, and then now institutionalize whatever our findings is, if it can be scaled up. Next slide, please. So what did we find in terms of research in mental health? We did find that relatively, we had a good number of local mental health studies, and a lot of them have been published in reports and also in journals as publications. So we do, relatively speaking, when you look at low and middle income countries or other African countries, we're not doing too badly. But however, one of the things that was striking when we looked at the research that was out there was that majority of these studies were very small sampled, included very few participants within them. Majority of them were cross-sectional surveys, and most of them were also involving hospital populations. The reason why this is important is because we know, especially for things like mental illnesses, a lot of our patients or a lot of the population may not even be able to go to hospital to seek care. Many of them, just out of the nature of the illness, makes them stay at home. So we might be missing a lot of information by just studying a small select population in the hospital population. And then using a small sample in a small area also means that we can't really generalize our findings. So again, there's those gaps that were glaring as we went along looking at the data that existed. And then we only found a handful of what were of larger population-based surveys, and some that were conducted in with the Moi referral team, Moi teaching and referral team, and Moi University in Gishu. We have a few in Kisumu County, and also the NACADA has done a number of rapid assessments. We have surveys, a lot focusing around substance use as well. So they're not national or countrywide. They're just small pockets, although they happen to be population-based. And then we also, implementation type of research was also lacking. Were very few research that are actually implementation type. And as we saw how we move from research to practice, at the point of evaluation, we're actually conducting implementation type of research, whereby we want to see how feasible is it, how acceptable, how cost effective is it, who should be receiving this care. I mean, that type of research is extremely important to be able to give to the policymakers and to follow through and be able to actually actualize it as practice. And then one of the key things that was striking is that though we do not have a national, we have not conducted a national survey that assesses mental disorders, and that is very critical. And in our next slide, just next slide, please. This is just a figure showing us at the tip of this strength of evidence pyramid, we have this systematic review. Systematic reviews means we've collated a lot of our own research, be it the case controls, the cross-sectional surveys, whatever it is that we are really focusing on. We've collated a number of them, and now we come out and say, from all this research, this is what is coming out strongly, and this is what really needs, this is the true picture of whatever issue that we are looking at. So again, we really need a number of studies for us to be able to come down and collect systematic reviews that are relevant to just our country, Kenya. The next slide, please. So what was our recommendation? In our recommendation, we thought we needed to undertake a national mental health survey. We needed to integrate a structured mental health information system, and we also need to increase funding for mental health research. As I said, though relatively not too bad for Africa, but very few studies, especially looking at population research, looking at implementation kind of research. So next slide, please, so that we can discuss why do we need a national mental health survey? A national mental health survey would be representative, first of all, and by saying it's representative, it means we will go to all parts of Kenya, sample the population, not necessarily go and ask each and every person about their mental health status, but sample the country in a representative manner and be able to now from that data be able to estimate the accurate information on prevalence. How many people have this particular problem, for example? What is the pattern? Is it the males, for example, who seem to have more? Is it the females? And also, what are the risk factors of this mental, neurological, and substance use disorder? So a national mental health survey will be able to address that. We can also, from that survey, can also be able to identify treatment gaps. Like, for example, the people we find on the ground with mental illnesses, we can be able to see how many have actually accessed treatment, how many are on care, how frequent is that care, look at disabilities, also look at social economic impact. And from this baseline data, we can be able to know, it will help us to inform and prioritize what exactly is the major problem, because the resources are constrained. So we need to be able to prioritize and see what is the main problem that is affecting the country as a wholesome. And to be able to plan for more cost-effective and relevant interventions. And once we've gotten that baseline data, when we do any subsequent surveys, maybe after a particular intervention has been put in place, we can be able to monitor the health and also evaluate the effects of that implemented intervention. So a national mental health survey as a baseline is extremely critical at this point for us as Kenyans. Next slide, please. The other recommendation was integrating a structured mental health information system. What currently stands is that we have in the health information system that we have, we currently only pick mental illness just as mental disorder. We do not have specifics on what mental disorder is. What the downside of that, first of all, is that even if we want to collect all the data from the health facilities, we're not able to really gauge what mental disorders are we talking about. Are we talking about depression? Are we talking about substance use? Are we talking about dementia or suicidal attempts? What exactly? So we are unable to really measure the burden. And this is really rich data coming from all the health facilities. And if it can be collected in a way that it can be used, even in terms of research and planning, then it would be more useful for us rather than having just an indicator called mental illness, which is what we have right now. So that was the gap. So we were suggesting we were offering as a task force that at the minimum, we need at least 8 health conditions being able to be recorded from depression, substance use, anxiety, bipolar, schizophrenia, neurodevelopmental disorders, suicidal attempts, and dementia. So aside from being able to record this and be able to actually see the burden, one good thing with being able to capture this kind of data is that even the healthcare workers, the frontline healthcare workers, they feel a need to actually screen for these conditions, look for these conditions, and they are able to identify them and manage these conditions because they are being they're being required to actually indicate what kind of condition it is that they've managed to see in the facility. So a system that is able to do this routine service reporting is extremely critical. Next. The second subsystem in this integrated structured mental health information system is around administrative issues. So being able to record the human resource available that is handling mental health issues, also being able to record drug and logistical systems, as well as financial information. All these feed into this mental health information system. Then we have a third subsystem that includes non-routine data. For example, if we have a program that looks at suicide prevention initiatives or mental health promotion in schools, then we can also be able to collect that data and feed it into this mental health information system. Next. So on the right, there's a figure there that now we are pushing that as a as a task force that this mental health information system needs to be plugged into the existing health information system. The current health information system would probably put in a lot more of routine service reporting, what I had told you about the 8 indicators. But also we need an overall sort of system, what we were referring to, like a commission, for example, that is structured and is able to capture even data on administrative system, on non-routine data collection system, on multi-sectoral data, for example, let's say from the education sector, and also be able to capture epidemiological research data that is relevant. What research have we conducted? What are the gaps? What is missing? And where should we prioritize? So all this need to feed into this mental health information system. Next slide, I think it's my last one. So about funding for mental health research, of course, when we increase local funding for mental health research, the more grants we have, local grants that we have on mental health, that target mental health, the more we incentivize scientists. We know there are very few scientists who are, let's say, psychiatrists or psychologists or mental health workers themselves who are conducting mental health research. But the more the grants come in, we'll have experts from all fields. One doesn't need to be a psychiatrist or a psychologist to conduct mental health research. We have epidemiologists, we have biostatisticians, we have people from different public health backgrounds who can come in because of that incentive that they are, local grants, and they can be able to join into the team, the pool of people interested in mental health research. So we need increased funding for mental health based on that. And by increasing the number of people who are involved in this space, then we're able to increase the number of research data that is coming out that is also relevant to our country. When it's local funding, it means the research we're conducting is relevant to Kenya. It's not sort of donor funded who kind of dictate what needs to be done or what their priorities are. We set our own priorities. So local funding for mental health research is extremely critical. Next slide, please. Yeah, so in summary, for research to inform policy and practice, we have to be thinking, are we investing in the right research that is accurate, that is relevant, and that is generalizable to the entire country? And is the dissemination process also, is it very clear, is it structured? For this to happen, we have to create a mutual understanding between the professionals working in research, the ones working in policy and practice. These professionals have to talk to each other. The researcher has to understand what the policymaker is doing and what their role and what they require from them. And vice versa, the policymaker needs to understand a bit of what research is all about and be able to evaluate and interpret this research and see if it's actually something that is usable and that should progress to policy and practice level. So these teams need to be able to have some more mutual understanding and working together to be able to come out to the pathway to the point of practice. And then the last thing is to establish incentives for working together. For example, that integral funding that we had talked about. Next, please. Yeah. So this is just a diagram just showing you in summary, the research integrity, then the influence based on the dissemination process, then research outreach, what we do with whatever research that has come out, and how we are able to talk to all the different interdisciplinary team and come up with solutions. That's it. Thank you. Thank you very much for your time.
Well. Thank you so much, Lynette. That was a brilliant presentation, which really cannot be summarized other than to say that what we should really be looking for is a system that gives us information that will guide the things that we do in mental health. In other words, if we don't have data, really we cannot have meaningful mental health practices. I will see what questions come to you. I suspect there'll be a lot of questions. We must now, with great speed, move on to Dr. Gedua, who will talk to us immediately. Yes, Oscar?
Correct,
About
Dr.
leadership. Yeah,
Yes.
if you're ready, you have the floor. But remember, Dr. Jogona has not spoken, so
Yes.
yeah, just take note.
I will.
Government has to
Okay,
speak as
thank you.
well. Mm-hmm.
No, I'll do that. Okay. So the same screen question, Dr. Macau, do you mind projecting? Thank you. As Dr. Makau is setting up, I think I'd like to start by saying that it's such a great opportunity to do this, to share with Kenyans and with anybody who is listening to us about what we came up with in terms of the role of leadership. Even before we get into the meat of the presentation, the one thing that I know we has always been an issue, especially when you think about task forces that have been put together and then reports that have been written, is normally who will take ownership of the document, and not only the document, but the contents of the recommendations that we have spoken about. So I think that we can begin by talking about that. So today, it is my honor to be sharing on the role of leadership and policies, especially as we move forward to enforce what, or at least to implement what the Task Force on Mental Health suggested. As we begin, the report can only come to life with adequate support as well as buy-in from all stakeholders. And while this is the position, the central role is the one that will be taken by leadership functions in terms of implementing the specific recommendations within the scope of their mandate of operations. So what am I saying? I'm saying that among the recommendations we were making, we were actually giving ownership to different leadership functions to actually be able to be the ones that drive it. And the one thing that I like about our report is that the task force report, is that we actually were naming the office or naming the people in charge who could be able to do something about it. So the role of leadership has actions that can be taken by functions found within a government generally. And when we talk about government, I'm talking about the executive, the legislature, and the judiciary. And I want to state, even as we move on, that in terms of the executive, the role we're talking about will be mostly administrative, given the way things are right now. And when it comes to legislature, it is about laws. And I'll talk about a bit deeper about that. And then, of course, for the judiciary, there is a function we've talked about in terms of, for instance, forming special courts, which will be dealing with mental health questions. Next slide, please. So as we continue, the majority of the weight must be felt by the executive to implement the recommendations, as we will be demonstrated. And the reason for this is because these are things that can be done immediately, many of which might not even require any financial implications. When Dr. Olaya was talking about the per capita investment for Kenyans, these are not the ones that will actually require that most of the times. However, they will actually just need somebody in an office somewhere saying this must happen, and I'll talk about them one after the other. Also, the role of the legislative and judicial arms of government cannot also be underplayed, because it cannot be understated, because without the laws, as we have talked about in previous webinars, and as well as delving deeper into the content of the task force report, if you see the kind of laws that are there, some that are derogatory, of course, others that are not, I would actually even dare call primitive, and others that are not progressive at all, you can find that the legislative arm will actually play a big role in being able to either repeal or to create new laws, or to even to actually even strike out some of the others. So for me, I think that's how to look at it. For instance, the legislative arm will have to be responsible for amending certain laws, like I've said, creating new ones, as well as repealing others. Next one. Next slide, please. So if you look, what I did is I decided to just take from page 82 of our of the task force report. I think, Doc, you've gone ahead. Just go the slide before that. Yes, thank you. We have what we call the recommended administrative actions, and you see that the way they are arranged in the task force report, and I don't think I could have put it in a better way. And I like the fact that because it's in a table, anybody can be able to follow it very clearly once you read the report, that we are saying that there are certain actions we're talking about which fall under the policy and advocacy reforms for mental health. We talk about who's responsible for them, and then what kind of outcome do we want to get from them. So I'm not going to go really deep into all of that, but what I'll do is I'll just talk about them and highlight the ones that I think will jump out to us. So for example, we have stated severally that we need to declare mental illness as a national public health emergency of epidemic proportions. And that's not just a statement that will be made from our homes. We have said that we will ask and task the Secretary to the Cabinet to actually put that on the table of His Excellency the President, and probably have the declaration coming from that level of leadership executively. And the result of this will be that there'll be a reduction of the burden of mental ill health and its impact on health and socioeconomic development. And we actually, the happiness index and the GDP will increase. And because we know, we have seen this before, we've said this severally as a task force, that during the time when the HIV pandemic hit Kenya, there was no mincing words. The president at the time, His Excellency Daniel Toroitich Arap Moi, he stood up and he talked about it being an epidemic. And what happened was a lot of legal issues, a lot of legal backup, a lot of policy backup came into effect, which also helped us to see the way we've been able to reduce the prevalence of HIV in our country from the 16 and above percent it was then to about 4.5%, as we can talk about it right now. Also, we are talking very boldly and saying that we need to have a directive by cabinet for the establishment of a National Mental Health and Happiness Commission. Why are we saying this? We're saying this because the overall empowerment in the happiness of Kenyans, as measured by the annual happiness index, will be directly impacted by this commission, whose responsibility, among others, around mental health will be to ensure that it advises government about questions to do with, how do you do policies? How do you make policies that actually are in line with promoting mental wellness of Kenyans? Also, we give the job to the Secretary to the Cabinet, and this is a good thing, because once that goes there, this mental health commission can actually report to cabinet directly and to be able to be an advisor to the whole of cabinet. Also, we talked about other things like the development of a national suicide prevention program, also the implementation of the mental health policy. This one is a really key one, because the mental health policy has been in effect since 2015, 2016, circa then, and we need it implemented because it's a very good document which can actually be able to achieve the objectives of mental health policy, which in itself, it talks about the governance of mental health, talks about the burden of mental health in this country. And I believe as a good document, we don't want it to die, we want it to be revived and to be implemented, because it is a product of the work of Kenyan people. Also, we talk about number 5, mainstreaming mental health programs across all government ministries. And we give this job again to the Secretary to the Cabinet, and this will be really key, because it will foster the establishment and operationalization of workplace mental health and wellness programs in all sectors. It is not going to become that after every company or every department in government has expended their budget on the operational budget, they say, oh, by the way, maybe we can go for a team building, and then they say that that's a mental health idea. We're talking about putting mental health requirements to be as part of the wellness programs of all workers in this country, because more balanced and well workers will actually lead to more productivity, thereby increasing our happiness index as well as our GDP. Also, we were talking about establishing of county mental health boards. This is a very, very, very important one, because in the system of devolution, we cannot rely on national government alone to be the leader of our mental health. We have to act and use the platform of devolution that we have right now, that to benefit our people in the unique way that our people present themselves across our republic. Please, let's go to the next one. Thank you so much. Also, we talked about declaring and gazetting the second week of October as a National Mental Health Awareness Week. And then we give this to also the Cabinet Secretary for Interior. So basically, what I want to say is this. If you look at the way we've planned and we have outlined each of these proposals and recommendations, we're saying that these are the proposals, these are the people who are behind them. So of course, I'll pick a couple from the health financing reforms for mental health. Dr. Olaya went really deep in talking about the per capita cost for each person. And we saw, if you calculate that money times the number of Kenyans that we have, the amount of money won't really be as much as we may think. It's actually going to be a better outcome for us if we can invest that way. Also, our national insurer, the NHIF, if NHIF can provide free cover for both inpatient and outpatient mental health services, then what we will be doing is that we'll be increasing access, which for us is actually one of the key things that we wanted to do and achieve, which was to say, can we increase the access to mental health services for Kenyans? And in this case, NHIF would be the person. Also, in number 10, if you see the Insurance Regulation Authority, who are saying that if they can enforce Section 46 of the Mental Health Act, with respect of exclusion of people with mental health conditions from insurance policies, it means that they just have to follow the law, because the law says you cannot exclude anybody who has a pre-existing or has a mental health condition as a reason for you to not insure them. So basically, if there is any insurer out there in our republic that has been doing that, they are breaking their own law. Our job as a task force to say, can we have people who are actually mandated to give insurance services, therefore follow the law and cover people who actually have mental health conditions probably. Also, tax incentives to promote financing of mental health and wellness programs by faith-based and private sector organizations. So we're saying that one of the ways to actually increase the funding in from even partners and probably from communities is by providing tax incentives. If people know that they can actually be able to get some rebates or whatever, what have you, what you will find is that more people will be interested in investing in this space. And as they invest, you'll see the quality of the healthcare increasing and having what we call multidisciplinary teams. And I would venture to say, just like Dr. Ongeri was talking about in the area of research, you're going to find multidisciplinary teams starting to work in the area of mental health in this country the way they're supposed to, just because of the availability of the funding to do so. Also, we talked about empowerment of people with mental health conditions and disabilities through the inclusion in social protection schemes, including cash transfers, employment quotas, and what have you. We were saying that for us, there cannot be an equal country if we do not include everybody who is affected by having a mental health condition or disability in activities of day-to-day living in this country. Let's go to the next one, please. Also, there's also the idea of improving access to quality mental health services in Kenya. Well, one of the issues we saw was about drugs. I do not want to say anything about KEMSA at this point, but however, you've seen from our point 13, we've already seen it from our own trips and seeing that there's a lack of medications in our national referral hospitals, especially the ones that deal with mental health. Even at Mathare, I remember we went to their stores and it was really sad to see that we did not have what we call the essential medications that are required. And so we were saying that if we could actually streamline KEMSA to ensure accessibility of essential second generation medications and equipment to enable the provision of quality mental health care at all levels, then we'll be making progress as a country in terms of accessibility of how it needs to be done. Also, that the gazettement and operationalization of Mathare Hospital as a semi-autonomous institution, this one I believe is already underway, and we really do thank the government for doing this, because we've been crying for this for a long time, to have it being run by its own board, to have its own budget, and to be able to be to have its own and autonomous thought and mind to be able to actually offer cutting edge treatment and cutting edge programs. Also, we talked about coordination across sectors of the regulation of treatment and rehabilitation services for substance use disorders by the Kenya Medical Practitioners and Dentists Council. Well, the idea here was really about the medical aspect to rehabilitation. Of course, if you're going to be having a facility that has nurses and doctors in it, there has to be some accountability at some level, and that will also be able to help us to police and to actually prevent quacks from running a rehab from their house or running it in the backyard somewhere without any actual vetting. Also, as you can see, there are very many things. And let me go to number 18, which talks about a directive to Kenya medical training colleges to include examinable mental health training curricula in the training of all healthcare professionals. Now, this is important because as previous speakers have talked about, in the idea of primary healthcare, and when you go to the clinics in your community, the question will be, will you get an assessment that only does physical health assessment, or can you also have at least a mental health screener that actually accompanies it? Are the people who are actually our medical practitioners on the front line, do they have the ability to be able to screen any mental health signals that might be prevented at that level? And so this is what we're saying. If this education is included, then we're going to see more people becoming mental health literate, which actually will help us to prevent some of the cases we've been seeing that have actually gone a bit too far. Let's go to the next one. So basically, I won't even go to all of this. You're seeing the idea. The idea is that we had all our recommendations in one column, and we had who was in charge of them, and we said what the outcome we were hoping to get out of it. So number 21, close to my heart, of course, being a psychologist, the provision of counseling and psychological services through the deployment of counselors and psychologists in schools and other sectors. And this is a big one because you have seen that probably even people like the TSC and the unions, they talk about having their teachers who've studied counseling, for example, and they're deployed. But when they're deployed to schools, they're not deployed as counselors or psychologists, they're deployed as teachers. So one of the problems that we've seen with this in the past is the dual role. If I'm a maths teacher and I'm also the counselor, and then the student comes to my counseling room and tells me the reason they don't perform well in mathematics is because they don't have a good atmosphere at home, when I'm marking their paper the next time, am I marking their disclosure in counseling or am I marking the skills? So you see, there's a problem there because we have to be able to delineate and to actually separate these roles so that at least there can be a more efficient provision of services, of course, with sensitivity. And I know this will take a long time, and we can begin at some point in terms of deploying people. We can give them that dual deployment, and over time, we can actually say, how do you separate all of these all of these requirements by having a standalone counselor or psychologist in every school, or even a mental health. I would even venture to say a mental health practitioner in a school who can be able to help out in any psychological issues that might come up. Towards the end of our proposals, we came up with ones that are cross-sectoral mental health reforms. And as I was speaking about the judiciary, the first one at number 22 is the establishment of mental health courts in collaboration with mental health professionals to screen and link to care special needs offenders with mental health conditions. This would be a huge, huge help because we would have a whole system of in the court, beginning with the judges, who I have to say are very mental health literate even at this point. But then can you imagine if we had it specialized, then what would happen is that these special group of judges and magistrates and what have you in the courts and the clerks and all would understand mental health terminology, would understand the conditions, would understand what delusions, hallucinations are and the impact that they have on the crimes that people have been accused of. So for me, I think this is a big one, and it will actually be a really key thing because of fair administration of justice and decongestion of prisons. Many times we found people who are in prison who probably are there not because when they're committing the crime that they actually were all there. In the legal term, mens rea, we can say that they did not have the presence of mind as they were committing the crime. However, if we have this kind of courts, we can be able to come up even with diversion programs which will prevent them from being locked up in your normal prisons, but they can go into treatment facilities or treatment programs which can be administered by mental health professionals. Also, we are talking about development and implementation of mental health literacy curriculum for the police service. And this is really, really for the prison service and defense forces as well. This is really key because the reason we came up with this was because these are the people who have the interface, especially from the executive with Kenyans. And, the way we are handled by police officers, the way we are handled by uniformed forces. I have to say, though, that over the last few years, this has been increasing. But if we were to say that this was to become part and parcel of their training, we would see a bigger shift. It is because of leadership that we have right now in all of the formations that we have seen that there's at least a more uptake of mental health questions and mental health training. However, we are saying that we'd like to see it more streamlined to make it a requirement. Also, I think for us, let's go to the next slide, please. I think that in trying to finish within our time, the success in implementing the task force recommendations rests in the ability for all leadership functions described in prioritizing those recommendations and following the implementation plan that is outlined in our report. Our prayer is that with these recommendations in full effect, the impact on the mental health system will be immediate and all Kenyans will experience an improvement in the mental health structures that will be available. What we are saying is that once these things are put in place, we'll start seeing leaps and bounds. We're going to grow in leaps and bounds in terms of a positive direction in our system. We're going to see a lot of changes there. And I know I've not gone through the laws because we had done that in a previous one. However, I can tell you that even those laws that we pointed out and the matrix that we actually went through in the annexes, if you go through it in the report, you'll see all the laws and what we're actually recommending for them to be changed. Let's go to the next one, please. In conclusion, as we finish, the current landscape of mental health in Kenya has been characterized by having a lot of gaps, which prompted the formation of the task force, as our chair, Dr. Njenga, said at the beginning of this webinar. And our work took us across the country, and the findings from listening to Kenyans pointed out to us that a lot still needs to be done. We have been able to capture as humanly possible, as with the time constraints we had in about 80 days, we're able to do that and to capture it in a way that hopefully can be understood by Kenyans, and we can read it and we can track the document, critique it, and see what in the day, all the recommendations we are making, all the responsible
Thank you, Dr. Gido. I don't know how to explain or describe this, but I think that was an excellent summary, almost of the entire document of the Mental Health Task Force report. And part of the reason that we allowed you to continue, Oscar, was because really those who are attending our webinars for the first time really will feel like they have attended all of them, because you've really summarized the very specific actions that are recommended by the team. Now, time is completely against us. We started late, significantly late, because we are using this new system. So before we take questions, and there are a couple of questions, I will ask Dr. Njuguna, by way of summary and a statement about a way forward, to kind of make the final remarks. Then we'll take a few questions, and then we proceed from there. I hope that is in order. Thank you, Dr. Njuguna. You have the floor.
Thank you, Chair. I hope everyone can hear me.
I hear you loud and clear. Proceed, please.
Yeah, so I would start by thanking you, the Chair, and all the panelists and the task member. You went ahead doing something. You just come with a report and handing it over to the Cabinet Secretary for Health on 7th of July. You agreed to participate in this dissemination process, which I think has gone on very well. We really, truly appreciate. So I think now more Kenyans are more informed about it, but we still ask Kenyans to go out there in our website, get to have a copy of the task force and read to have more details on this. As a way of concluding this series of webinar, I would say that we'll continue disseminating this report, but beyond disseminating this report at other levels, that is at the Ministry of Health, but also we'll ask our stakeholders, wherever they are, to participate in this process, getting that these reports goes to the people at the grassroots level. In a very simplified way, they can engage us as the ministry. We see how we can be able to do this in terms of using the mass media, especially now that we can't have a huge gathering, but also using technology like the webinars and any other ways in which we can disseminate this. That is the first aspect of what we call public education, ensuring that the Kenyan understand this is what they said, this what was put together, and this is what is expected of the government in terms of moving mental health services to the next level. The second item is at the level of the government. You know, the national government has a key mandate in terms of looking at the policies, and so we need now to convert this report into a policy document, into the necessary instrument which can make it be able to be implemented. That is coming up with plans. And then these plans should be try to see what could be of first priority in the first 5 years and how it can work within the finance mechanisms of government. So we need to have a mental health plan with specific targets and indicators in which we'll be able to measure that we are able to achieve what is within the report. And these will go together with the other necessary instrument to make it possible to be implemented. First and foremost is that the county must be able to take up these plans. They may customize them depending on the way different counties' structures are. But very important is, are they able to put investment? And that's why the topic today was investment. Investment in terms of mental health financing, that there are budgets for mental health. And these budgets not only look at curative services, they look at even promotive and preventive services, building up systems within those counties, and putting all the structures and systems which may ensure that services are provided. So that is at the policy levels that we need to have the plans, and these plans must also be done at the same way at the county level and provide investment. The third element around investing this document is to see that there are a number of legal reforms which will be required, and we'll ask the ministry can institute a bill, but also now any member of the public, as per our constitution, has the right to initiate what we call a private member's bill in parliament. We already know there's a mental health bill in parliament, which probably, as recommended by the task force, will require some few amendments on some few issues which have been raised by Kenyans, and then it can become law. But there are other laws beyond the mental health bill or having a mental health act. If we are to address all disparities around mental health, we need laws which, anchor very strongly the issues of financing. We need laws which address issues about inclusion, empowerment, and the rights of persons with mental illness. So we need to look at all that. Some laws will require amendments. Some laws will just require new registration. Very importantly is that when you talk about the law, there's one key law which need to be addressed, the Penal Code, Section 226. It's just one single sentence which criminalizes attempted suicide, and you know the impact that has in terms of mental health. We need government can initiate that amendment, but also the Kenyans, the citizens, have the right to initiate that kind of amendment. So that is at the legal level. Then policies and laws will create structures and systems which need to be built so that we can have mental health services. When we talk about community or primary mental health care services, then it means we need structures and systems to ensure that there is primary mental health services. It means we need the human resource. So there are actions about having more human resource. We need to have programs, and these programs can learn by not only the government, we need the private sector to learn the mental health programs. We need to see the faith-based organization learn programs, NGOs, which are captured well within the policies and the plan, but they become a player in delivering this to the people themselves. Even people with lived experience can have support groups. So how do we ensure this happens? We need to have structures and systems. And so that is another area of investment. that we have human resource as part of the system. We have infrastructures for services. We have technology, because right now we have to use technology, like we need to start using telemental health. So we need infrastructure put in place. And these not government can do. We invite every Kenyan, wherever they are, whether it's the faith-based, private sector, county governments, philanthropists, researchers to put these infrastructures and systems. But there are some systems and structures which maybe they are within the law. Like we are talking about the commission, we need to establishment of the commission, we need councils and other governance structures which just require some administrative action. Lastly, I will maybe talk about monitoring and evaluation. We need to monitor whatever we do. We need to put targets, and within a period of time, we are able to see this is what we are doing. And so the role of research and data is very important in this, that we need to improve on our information systems and also having more research. That everything we do is not just from hearsay, it's evidence-based, is the best and meets the international standards, and it's delivered in the best way. So, Chair, I think those are some of my few points I can, say concerning as we move forward, what we expect to do as regard this report. Thank you.
Thank you very much, Director of Mental Health. And that brings us to the end of the formal presentations. We have a few questions, and what I will do is I will now ask all the panelists to prepare a parting shot. What being in the mental health task force meant for them, what did they learn, and what are the final words they would like to speak on this webinar today. So I will ask Dr. Olayo to go first with the question from Mary Chege, which is, would you kindly ask the private insurance organizations to have packages for mental health? Dr. Olayo? Answer the question, goodbye.
Thank you very much. I think I'm glad that they raised the issue of private health insurance and the need to cover mental health. So it's both good news that the law actually is on your side, that they should cover mental health services. And I think Dr. Gedua talked about it to a great detail. So it's just a question of enforcement by the insurance regulatory authority to ensure that they follow. All the people that they regulate do not discriminate against people with mental illness. But I have bad news for you. I think when we look at the country as a whole, our private health insurance just covers a really, really small percentage, just around, I would say, 3 to 5%. So eventually, the package is also very slim. So if you need prolonged care, they'll find a way of either exhausting your cover or knocking you out after some time. So we still really need a major rethink of how we are financing mental health services in Kenya in a way that protects everybody. All these people with private health insurance, they kind of run through them fairly quickly. And even those who are carrying the card and that are eligible, especially the employer-based scheme, they still end up paying significantly out of pocket after some time. Now, my parting shot for being in the mental health task force is that I learned a lot about this subject area. I'm coming out with a heavy heart because the area is greatly neglected, both at the family level, at the community level, in our education system, and more so at the highest level of policy. And we therefore need to advocate very strongly for everybody concerned to pay a little bit more attention to prioritize mental health, because the benefits of a healthy nation far outweigh any investments that we could put towards the care of our brothers and sisters that need these services. So that would be my closing remark, Dr. Njenga, and thank you
Thank
so
you.
much for your leadership of this process.
Thank you. Thank you. Oscar Gedua, parting shot.
Thank you so much, Dr. Jenga, for chairing this task force very ably and with a lot of knowledge. And I think that it cannot be understated the way the leadership, the calmness. It really helped the rest of us to really do our work well. For me personally, it's been a great honor, personally as well as professionally, to work alongside colleagues who are true sons and daughters of this land and who are patriotic. I think that the one thing that I would love to inform anybody who might be watching this or listening to us is that because of being appointed, when you're appointed to a position like this, it's very easy for you to engage in political bickering or political posturing. But what I can report from where I sit and in my experience is that everybody applied themselves selflessly, and everybody had so much other things to do. The people on this task force are professionals in their own right, but everybody gave their time for it was not about any money. Actually, it was more about dedication to this country. I learned a lot, and I'm deeply indebted to Kenyans for give this opportunity to have served them and to listen to them across the nation about what their really deep concerns about mental health are. And I'm actually proud as a parting shot that there is hope for us in this country, because what I've seen both from the side of private practice and the side of government in the leadership of Dr. Njuguna and the team at the ministry, for me, I think that we are in a better place than we were a few years ago. And I think there are only better days coming ahead. And finally, if the recommendations that we as a task force have made after all the work that we did can be implemented following the plan, then I think that our country will actually start to heal. And I think with that, I'd like to thank you so very much for giving me this opportunity. Thank you so much.
Thank you, Oscar. Lynette Ongeri, parting shot.
Okay. I think what I have learned from the task force experience, it's been extremely an eye-opening experience, being able to talk to, especially in the public participation aspect, very eye-opening and very humbling experience. And as Dr. Olayo mentioned, I personally moved from that stage of being more of a research scientist to being an advocate. And we all need to move to that stage of advocating for better mental health care for our country. And especially the thing that struck me most was around the caregiver burden. And it's highly neglected, and we really need to think about the caregivers, how we can support them and what needs to be put in place. So it really helped me think outside the box of just being a scientist or a researcher and just by research to how do we advocate for things to really change when it comes to this mental health space. And again, I'd like to also thank you for your very good leadership. You really steered the ship very well, and we were able to work together and come up with a really good document. As far as I'm concerned, I think the document is really good. Now it's up to us and the rest of Kenyans to work together to implement our recommendations. Thank you very much.
Thank you, Dr. Njuguna. Parting shot. Time is going.
Yeah, so my parting shot is to thank you, Chair. I think this has been an excellent. I think the work have just started, but you have made the work start by coming up with this report. I also take this time to thank all Kenyans because they came out, especially during the public participation, and they provided what is the situation on the ground, what they think could be the practical solutions to the issues on the ground. And more, I appreciate the team, all the task force members, the secretariat, they were able now to put this together. So I urge all Kenyans, the journey has begun. We need to continue being together and move to the next steps of implementing this and transform mental health in this country. Thank you.
Thank you very much, lady and gentlemen. Mine is to thank the government and the people of the Republic of Kenya for this incredible opportunity to serve them. I hold the view that we put our best foot forward, and that this living document will, we hope, find full and complete implementation, because that seems to us as a task force as what His Excellency the President had in mind on the 1st of June 2019, when he spoke about the increasing burden of mental disorders in our country. The second thing I'd like to say is I found it extremely easy to chair the task force because the men and women who were members of the task force, as well as the secretariat that was given to me, were all, without exception, extremely able men and women, which is something we don't say often. That in fact, this country, in spite of all the complaints, and we have many complaints, some genuine, some not so genuine, that in fact, if one looks hard enough, one is able to find and identify meritorious men and women, equal and sometimes exceeding the tasks that are put before them. I will, without fear, like to commend one group of men and women that we found at Mathare Hospital, who surprised the task force almost in its entirety by their commitment to serve under extremely difficult circumstances. Dr. Jogona, if you see them, tell them the task force commends and congratulates them for their selfless and competent work. And from what we have heard so far with the interactions with government at the point of receiving this, our report, the future for mental health, not just Mathare, but the future of mental health in general in our country is very, very bright indeed. On that very happy note, ladies and gentlemen, we come to the end of this series of webinars. We will, in the course of time, notify the true owners of this report, which is the people of Kenya, of any other further activities that we may be carrying out. Ladies and gentlemen, many thanks to all of you for attending, and to the Republic of Kenya and her people, many thanks for the opportunity to serve you. Thank you and goodbye.